Hello, everyone. We're excited to welcome you to the Sepsis Town Hall. My name is Annie Allen, and I'm a Clinical Quality Improvement Advisor at the Wisconsin Hospital Association. For those of you not familiar with this technology, we're using a web-based video conferencing platform called Zoom. As of now, all of your video feeds are active, so if you have a camera attached, it's on. Your microphones are also unmuted. In order to minimize feedback and have good audio quality, please keep yourself muted unless speaking. Even though there are a lot of people present today, this is meant to be an interactive event, and we encourage questions and discussion. If you would like to speak, please unmute yourself. As a reminder, once again, mute yourself when you're finished speaking. This event is being recorded, and a link will be placed on the Quality Center website. So let me now go ahead and introduce you to our facilitator for today, Dr. Bobby Redwood. Dr. Redwood is a graduate of the Rush University School of Medicine in Chicago and the University of Wisconsin Emergency Medicine and Preventative Residencies. He works full-time as an emergency and preventative medicine physician at Divine Savior Hospital in Portage, Wisconsin, and is chair of the hospital's Antimicrobial Stewardship Committee. Dr. Redwood also teaches resident physicians and publishes research as a clinical adjunct professor for the UW Department of Family Medicine. Recent publications include Severe Sepsis Care in the Emergency Department and Antimicrobial Stewardship in the Emergency Department. Outside of work, he serves as a national counselor and past president of the Wisconsin chapter of the American College of Emergency Physicians. So now I'll hand it over to Dr. Redwood.
Thank you, Annie. And welcome everyone to our Sepsis Town Hall event. So you have all been with us on previous webinars, and in the past we've done more of a presentation format. And sort of in the in-between time of these webinars, I get a lot of emails about hospital-level issues. So, specific issues to my hospital. My orthopedic surgeons want us to hold off on antibiotics until they are able to tap a joint. Or every time we, admit someone to the floor, we find that the lactate's falling off. Or when we have float hospitalists and we upgrade someone to a level of care, we sometimes don't flag sepsis vital signs at that time. These really granular, specific questions to your hospital. And I'm sure you all have them, right? So we are now in the era of public reporting of sepsis data. You can go to hospitalcompare.com and see where your hospital stands. We know that in Wisconsin, we are around 50% for statewide compliance, which puts us right in the middle of the pack. It's a pretty tight spread. So Florida is number 4. They're at 56%, and then down in the bottom 10%, people are pulling like 44, 45. So it is a pretty tight spread. But we always are asking ourselves, how can we make ourselves better in Wisconsin? How can we improve compliance with the SEPSIS-1 bundle? And I think that's why we're here today. Is I really want to hear from member hospitals, from your on-the-boot perspective. What are you struggling with? I think every one of us has some issue when we break down that sepsis measure by specific metrics. What are we struggling with this quarter? And I'm going to make this an open presentation, really facilitating different categories. But feel free to break the rules. You can ask your question at any time. If we're talking about definitions and you want to talk about antibiotics, that's fine. You can go backwards. You can go forwards. This is really for our members. I have no conflicts of disclosure, and this is the topic outline. So when I go through my slides, we're going to talk about definitions, data abstraction, sepsis triage, et cetera, et cetera. So you can sort of look at the slide and get a basic idea of what we're going to be talking about. And if you know that one of your questions fits cleanly into one of these categories and you want to jot it down and wait for that category, that might be, that might fit the context well. But we'll absolutely have time to go through all of these. And I won't be presenting as much. I might prompt you with a question or two, but I really encourage you to chime in and ask your questions about sepsis. I am going to leave some silence. That's your cue to ask questions. So when we get to a new topic, if nobody's spoken up yet, we might leave it open for questions and see if anyone gets inspired. And with that, we'll dive right in. So obviously, there's been some changes in 2018 to the sepsis definition. There was a big push from the Surviving Sepsis campaign to use the Sepsis-3 definition. And as you know, the SEP-1 criteria from CMS has not changed. They are still using Sepsis-1 criteria and the SIRS criteria. So that's created some confusion, I'm sure, among hospitals. Does anyone have questions or issues about the definition of sepsis? Or has that created compliance issues with your med staff, with your MDs, your APPs? Is there confusion among the doctors and nurses? What's going on the ground at your hospital?
here at Riverview,
Oh, go ahead.
and to here at Riverview, our providers haven't really changed much because they're driving up to the CMS step 1. So long as we're not changing anything up to the CMS step 1, they are fine with that. We've jumped over that hurdle earlier.
Thank you, Riverview. Yeah, we're doing a similar approach at my hospital. And someone else was about to chime in there.
This is Debbie from HSHS St. Vincent. We're using the step 1, and we don't have any pushback or anybody discussing step 3 really. So we're doing the same as you guys.
So this is great. Sepsis 3, you know, the science is always advancing, and Sepsis 3 is not a way to diagnose sepsis. It's a way to sort patients into different care environments. Who needs that highest level of care, the ICU environment? And so the definition for Sepsis 3 is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So it's this very nuanced, very nerdy definition of sepsis, trying to hone in whose organs are failing, who needs one-to-one nursing care, who needs their, you know, labs checked every 6 hours, things like that. And it doesn't really mesh well with the art of the SEP-1 core measure, which is screening for sepsis, identifying it early in the ED, and getting care started early. And so I think there is some natural tension there. We have been at the Hospital Association giving broadly advice to follow the SEP-1 criteria in terms of your ED triage and your initiation of care. And then if your clinicians want to sort patients subsequently using a Q-SOFA score or the Sepsis 3 definition, that's obviously perfectly appropriate. And I think that this tension we're experiencing now is a very natural tension. The definition is evolving, and the sepsis core measure is still very valid, even though it is not necessarily using the language of the Sepsis 3 criteria. And, you know, this obviously the SEP-1 core measure is evolving with the science. And so we'll see if there is an update using Q-SOFA or Sepsis 3 to the core measure. We'll keep you guys posted immediately if that happens. But from what I'm hearing from the 2 people who chimed in, sounds like Sepsis 1 is still working. And if you're listening and say, oh, actually, there have been some issues in my hospital, and you want to chime in at any time, feel free to do so. Now, I know there was a very rich webinar just last week on data abstraction and reporting. For quality professionals on the line or data analysts on the line, do we have any specific questions at your hospital about data abstraction and reporting on the SEP-1 core measure? How are things going? It's a heavy lift, I know.
Dr. Redwood, this is Monique again over at Riverview. What are your thoughts, or what have you heard regarding using abstract, when a doctor dictates and using the information in that dictation, because it reflects what their thought process was, but it's not date or time stamped until perhaps 24 or 48 hours later. The ability to, or should, you know, use that information with the abstraction. Is that impeding?
Sure. Yeah, I mean, most medications, most lab orders are time-stamped. And so, in general, we go with the timestamps in the chart. But I would say if your physician specifically says something other than that, there are absolutely, when you're talking about clinical medicine, there are absolutely occurrences where, for example, the first lab was hemolyzed, and then you didn't get your lactate back for another hour, and that's when the patient fell into the sepsis criteria. You might have the first lab order still on the EHR. So it says the first one was drawn at noon, when in reality the clinician didn't have that information until 2 p.m. Well, if the physician says that, I think the sepsis chart should start at 2 p.m. You have a very convincing argument there, and you just have to make a note that the initial timestamp was incorrect. Does that answer your question?
Yes, thank you.
Yeah, I think on the ground clinical perspective should trump timestamps in the chart. You know, by and large, medical professionals are honest. They are trying to reflect what is actually going on, and the timestamps are very useful when it's not specifically noted. But if somebody kind of overrides that or gives more on-the-ground information, that's probably more realistic information. We're trying to get at the truth here. So, you know, this is tied to payment, this is tied to hospital quality, et cetera. But really, we're trying to get at how is our hospital actually treating sepsis? Are we actually helping patients? And as long as you put the patient in the driver's seat and try to reflect reality, I think you really can't go wrong. That's a great question, though. I was surprised. I thought definitions and data abstraction would be big topics, so you can definitely go back to them. And, you know, if it ends up we have a lot of questions about the science, about the 30 cc's per kilogram and the vasopressors and antibiotics, that's wonderful as well. Sepsis triage. I'm hopeful that everyone on the line is triaging for sepsis in some way, whether that is RN abstraction or RN triage in the ED, whether that is physician triage using a standardized triage tool like that CMS releases. What are people using? How is it working? Is it clunky? If so, why? What questions do you have for us?
This is Monique again. I'll take advantage of the feedback and the opportunity. With the triage, have you seen a difference or heard of a difference between if the ED providers are using other order sets versus a sepsis order set or triage order set, and their ability to actually get to sepsis sooner if they use strictly a sepsis order set? So let's say you're working up weakness, and then, you know where I'm going with that?
Oh, I see what you're saying. Yeah, if we have found, so one thing we do at the Hospital Association is we look for best practices. So we look at the hospitals that really seem to be acing this measure. They're missing very few cases of sepsis. They're having few level of care upgrades. They're treating people early and having good outcomes. And we say, what are these hospitals or what are these health systems doing? And then when people are not, you know, meeting those as well, we say, oh, is there a gap here? Is there something that the high performing hospitals are doing that you're not doing or that you could improve on? And that's sort of the best practices we're looking for. And we have found time and time again that one of the best practices is to screen for sepsis vital signs, so for SIRS criteria, in ED triage, and then again when you're admitted to the floor. So those are kind of the two key times to touch the patient and say, do you meet SIRS criteria? And largely that's nurse-driven process. And if that patient screens positive, then there needs to be a conversation, a nurse-physician conversation. This patient screens positive for SIRS criteria. It doesn't mean they're septic. It doesn't mean they have septic shock. It means they screen positive for SIRS criteria. And that's when the physician really applies the art of medicine and decides whether or not this patient is high risk for sepsis or maybe septic. And if the physician does have a suspicion for that, they should be using the sepsis order set. That is the best practice there, is the use of sepsis order sets. Because if you're using a weakness order set or a STEMI order set or a UTI order set, it's not going to have those key components. It might not necessarily have blood cultures ×2 before antibiotics are given. It might not necessarily have 30 cc's per kilogram normal saline or a broad spectrum antibiotic choice or a peripheral lactate, which are kind of the key aspects of the 3-hour bundle. And so I think it is important that the physicians use the sepsis order set. Now, you may be scratching your head and thinking one of two things. One, do we have a sepsis order set? If you don't have a sepsis order set now, that's a great time for a creative QI project. Get a physician champion, look at the order sets in the ED and say, how can we create something that's useful for clinicians? Or you might be scratching your head and saying, oh, nobody's using the order set. That's probably the more common problem, and I get that. We as physicians are not always aware that the order sets are out there. We might not be aware that they are, or we might not like the order sets and have a kind of a workaround. And if that's the case, I would really encourage you to do a QI project to make your order set good. And that requires a physician voice. You need to have a physician sit there and talk to his or her colleagues and say, why are we not using this order set? Is it in the wrong place? Is it too clunky? Are there too many clicks? And lots of times you can find ways to make that order set work for you. It should basically have the bare minimum that you need to provide accurate sepsis care without sort of, 50 orders that really overwhelm your physicians. And so I think sometimes those order sets are just, pulled from Epic or put together based on IT looking at a website. And your hospital might be really different than that standard experience that people are finding online. And so that's a way that you can really customize it to make it a good experience for your physicians and make people use the order set. Long answer there.
Thank you.
Thank you, Monique. I'm looking for others out there too. I want Monique to keep speaking up too, but I know I think we have 20 plus on the line here, so. Are any member hospitals out there using best practice alerts, BPA, or code sepsis in terms of sepsis triage? And if so, how is that working for you?
This is Debbie from St. Vincent's. We have BPAs and we don't have much luck with them.
Tell me more. People just ignore them or click through them. They're, you know, is it alert fatigue?
Alert fatigue. They just too interrupted, too many. They become immune to them.
And they're being alerted for SIRS criteria. Is that correct?
Yeah, for SIRS criteria, and then it'll, once the labs come back, it'll alert them again, like if they think they have severe sepsis or septic shock.
Yeah, you know, you're not alone. The goal of this core measure is to get people to snap into critical care mode, to activate a team like we do for STEMI or for trauma or for stroke, and really be on top of sepsis. The problem is, of course, that there are false positives out there. You know, flu season, for example, pediatric patients, panic attacks, asthma exacerbations. There's a lot of false positives. And so if we screen too early, we run the risk of alert fatigue like you're experiencing. And so for some hospitals, it's working well. We have had member hospitals that report it's not an onerous BPA and that people are actually using it and seem to be able to, you know, whatever algorithm they've used to make their BPA function is functioning well. And then we've had some hospitals that are showing alert fatigue like you're mentioning. A happy medium that I found is to alert for septic shock. So when the blood pressure actually goes down, that seems to be clinically useful enough and not have as much noise as alerting for SIRS criteria. Another thing you can do is just make your initial BPA just when an ED patient flags for SIRS vital signs, sort of have a box in the EHR around that patient or a single click to get through then, just to jog the clinician's thought process. That doesn't seem to be too onerous, that kind of one-time touchdown, but it is tricky. If you have sort of throughout the process multiple BPAs, we as clinicians can get into auto-click mode and get through those. We're also, we're 3 years into this measure, right? And so I think that's a question to really about sepsis in general is, has identifying sepsis early and occult sepsis become part of our culture, or is this still seen as sort of an annoyance, as governmental medicine or cookbook medicine, something that people are just trying to get around? The goal, obviously, is that we're identifying patients because we want to be, because we're concerned about severe sepsis and occult sepsis. And then the danger is that this is just something that people view as another metric we have to get through. And I think a lot of that perception in your emergency department or in your ICU depends on your physician and nurse champions. Do they take their role seriously? Do they really believe in the mission? Or is this kind of one of these things where, hey, we're just working on our numbers and it's become rote? And that's an open question as well. If it's become rote at your hospital, what have people done to overcome that challenge,
This is Kathy at Aspire Sling Lady in Anago, and we have a nurse triage order sets that the nurses can implement that were approved by the providers on a general level. And the sepsis one triggers the lactate and the repeat lactate, and it just kind of serves as, like you said, a trigger or a reminder to the providers that, hey, based on what we're seeing here, this is what we think. And they can always add, they can subtract if they choose to, but at least we're trying to catch it on the front end.
I love that. Thank you, Anago, for speaking up. I don't know where this practice in medicine came of everything's done as doctor's orders only. I think there's this old school vision where if the doc doesn't say it, it can't happen. And anyone who's ever worked in an emergency setting, which is where we're diagnosing most of our sepsis, knows the value of that nurse-physician dyad. I am with my patients maybe 20 minutes their entire visit, if that. The nurses might be with them for an hour and a half. They know when our patients are doing well. They know when the care plan is not working. They're there to communicate with you when the patient is deteriorating. So to have a seasoned triage nurse or a charge nurse actually looking at patients and helping determine if they're septic or not and getting that order set started early is just so fundamental. And when we do quality initiatives like this, the goal obviously isn't to just treat sepsis. We want to increase that physician-nurse communication so that no matter what the pathology is, your nurses and your physicians are talking. The worst thing you can have is one room over here where nurses are working, one room over here where physicians are working, and they only talk when something goes wrong, right? That's like the most toxic environment that you could provide emergency care in. We want to have constant lines of communication open. We want to be keeping abreast of the patient, evolutions in their care, from triage to discharge or triage to admission. And so I love really getting on top of that early, empowering the nurses to order some labs when they're appropriate. The physicians always have veto power, obviously, but it sounds like in your hospital, the trust is there, which is what this is about. It's about building trust and really thinking of patient care in a new way. That's why these quality measures exist. So I really like that, and that is a best practice for those out there, is for nurses to have the power to put in the sepsis order set, and obviously you can always cancel it, right? If some evidence comes out of the woodwork that no, this is actually more of an asthma exacerbation, we really have low concern for sepsis, we don't want to keep this patient here for all these labs, you can cancel the order set and reroute the workup. So, but thank you for speaking up.
You're welcome.
So that's sort of a natural transition into RN versus MD roles. When we redefine a clinical entity, for example, STEMIs, we are often assigning roles. And Anago just gave us a great example of triage nurses putting in an order set for things like blood cultures and peripheral lactate. How have the RN or MD roles evolved or not evolved at your hospital? Are there issues? Is it clunky? Is there a culture change that's not happening?
This is Kathy again in Anago. I can tell you from our experience, we had some huge issues with provider and nursing roles. It was like, I'm the doctor, you do what I say, and that's the end of the subject. Fortunately, that has changed. That's done a 180 due to a lot of circumstances, but it just has, nursing now doesn't have a problem going up to the doc and saying, are you sure that's what you wanted to do? Or, boy, you put orders in on the wrong patient, or whatever it is. I mean, we have got to have each other's back, or the patient's going to suffer.
Absolutely. Practice makes perfect just in life. So the more that we talk to each other, the better we get at it. I know that, one of the from a physician perspective, one of the annoying things, you're on shift and you hear about that lactate of 2.1. It's flagged as a critical lab. Hey, this patient has a lactate of 2.1. It's one of those false positives we're talking about. You get a lot of these kind of low-level lactates that don't really seem to correspond to infection. And you kind of do this internal sigh and say, wow, am I about to place a central line and embark on a big workup, or is this just noise? And whenever I hear about those critical lactates that are in that intermediate range, I start my response with thank you. Thank you for letting me know. I'm not concerned about sepsis at this time, but let's go ahead and trend the lactate. We'll see where this goes. Or thank you for letting me know. I think this patient has already turned the corner. Hopefully the follow-up lactate will be below 2. Let's see where this goes, kind of thing. And just having that conversation, though, multiple times per shift really does open up the communication lines. It's funny, too, it's so personal. You might have one doctor and 20 nurses. Well, some of those nurses might be float nurses, or they're coming from a different care environment, or they're just, they're casual and don't work so frequently. And so if you're a casual nurse and you're working with your doc and you're not really sure where they stand on things, and then you see everybody chatting with the doc about lactates, about the sepsis workup throughout the shift, it really does open those communication lines for any topic, which I think is the goal to providing good clinical care, is that strong physician-nurse dyad. And thank you for mentioning also that the culture was a little bit rocky at first. I think a lot of us have experienced that. Is the culture still rocky? Is there any infighting going on? Has sepsis destroyed your physician-nurse dyad? We can gripe too, it's fine. Okay. Moving on to blood cultures. Are the bottles in the department? Do you know where the bottles are? Are antibiotics being ordered before or given before the blood cultures have been drawn? Are phlebotomy and nursing fighting about who should draw the blood cultures?
Yes.
Good. Someone said yes.
This is Riverview. We were having some issues with blood culture contamination. So one of our steps to improve that was actually getting that all back to the lab because they had a lower rate. But now we're worried about how that may impact for sepsis in particular, the ability to access that lab in a timely manner and have them do the blood culture. So everybody's experiencing.
So tell me more about a timely manner. Like what kind of delays are you seeing, if you don't mind sharing?
We don't know. We just implemented this new process with having it all the lab draw them all. So I'm not exactly certain. For us, and we're not going to be complaining. It'll probably be looking at like an hour, maybe 30 minutes to an hour potential, depending on where that lab is. So in reality, that's not that bad, but it is an hour.
Yeah, absolutely. So part of the SEP-1 core measure is also about breaking down silos. So, sometimes we feel like medical care's lab is doing their thing, imaging is doing their thing, ED is doing their thing, ICU is doing their thing. And we really have to ask people sometimes to change their workflow. So what we just heard was an example of a QI project, a PDSA cycle. It's a small test of change. Let's try doing things different. Let's try adapting the way that we do things. And is it going to work? That's a great question. It might not work. But it might work as well, right? So how do we actually change the flow of things? I cannot emphasize enough how important it is to get lab on board with the sepsis core measure. So if you're having your sepsis meetings and lab doesn't have a seat at the table or isn't on the email chain, that's probably a key stakeholder who you want to get involved as early as possible. It might mean a pager, and a sepsis page goes off for lab, and they have to drop what they're doing and go down to the ED for their next draw. Really, like as a phlebotomist, I think people are used to doing their rounds, right? You go to bed A, B, C, D, and then you start the circle again. And part of the, when a STEMI comes in, you have to run down and draw the trope. Well, when a septic patient comes in, you got to run down and draw the blood cultures and the lactate. It's just part of doing business. There are carrots and sticks that you can use. So, for example, revenue streams, right? So you can say, hey, if you guys can't get us our lactate in time, we might have to have an ISTAT in the ED. That's a little bit more of a stick type scenario, but you really want to keep patient care as the focus of things and try to nudge those other key stakeholders to change their workflow. Lab isn't getting dinged on sepsis the same way as clinical medicine is, the same way as the ED is getting reported or the floor is getting reported, but they're just as fundamental to providing good patient care. And so working on your hospital culture and trying to do small tests of change with lab or other key stakeholders is fundamental. Again, long-winded answer there. One innovation we did at our hospital, we have in-house EMTs actually. And so when the EMTs aren't on call, they'll do things like blood draws for us. And so they're very on top of the septic patients when patients screen positive for sepsis and are sort of available there to augment phlebotomy or nursing if they are spread thin at that time. And so, it's a care innovation. What resources you have available, who's on deck to potentially fulfill this role if it's going to be a time delay. And if blood cultures are taking a long time, still give antibiotics. It's more important to administer antibiotics early. That's one of the things I think sometimes concerns me is that if you get too focused on doing the metric right, you forget about good patient care. If it's going to be an hour to get blood cultures, you still got to give that antibiotic. And you might be contaminating your results, right? But that's just part of, that if you know your health system better than anyone else, if that's happening, you might have to make some tough choices on the fly and suffer some lower compliance rates with your metric until you get the bugs ironed out.
Thanks for sharing that, because that is something that we had looked at, is if the provider noted that there was going to be delay in the blood culture, and that's why the antibiotics were being delivered, sooner, that actually is an exception on the abstraction, which is nice. So we talked about how well we should, publicize that, because we don't want to promote it, but we want it there if it needs to be.
Yeah, absolutely. And I mean, you can keep internal metrics that aren't measured by CMS, right? So you could say, how many times at our hospital, of the last 20 times blood cultures were drawn, how many times were they drawn after antibiotics were administered? And if you're finding that's 25%, that's something that you might be able to bring to lab's attention or bring some data to the table to make your argument more compelling, to have more resources funneled towards the ED or the floor, wherever the hang up seems to be.
Thanks.
Yeah, this is real life, you know. It is not it's not as easy as looking at a checklist and just getting it all done. So this is a big topic. How do we feel about the peripheral lactate? How do we feel about the cutoff of 2.0? How do we feel about that repeat lactate that's usually done in a different care environment? What's working for people? What isn't working? What questions have you had come up?
This is Kathy and Anigo. One of the issues that we had, and I honestly can't tell you if it's resolved yet or not. There's 2 other people on the phone that might be able to answer that. But we'd get our first lactate, and then Epic is our EHR. The patient would be admitted to the floor, and then that second lactate either disappeared off the order set, and there wasn't communication and whatever, so it didn't get done, or the patient was still in ER, and for some reason, I know a lot of it is the provider was using the wrong order set, and we're trying to resolve those issues, but that second lactate just seems like it's a black cloud, and we keep missing it for some reason.
Yeah, so I've heard that a lot. It does seem like there's some functionality in Epic where when the patient changes to a new care environment, the order set sort of restarts. And Antigo, are you part of, is it the Aspire system, is that correct?
Yes, we are. Yep.
What I would do, I know that there's a workaround for exactly this problem. You're not alone, and it is outside of my level of expertise to describe it. It's an IT issue. But what I would have is your local IT person talk with one of Aspire's larger hospitals, with one of their IT hubs, and ask specifically, how do we get our repeat lactates to carry over to the floor environment? Because I know there is a workaround for this, and it's something that the IT professionals could help you solve. I just don't have that level of granular detail to answer that for you.
Yeah, and I know that our quality was on top of that and was kind of trying to find out, hey, what happened? So I'm hoping that we get an answer to it or figure out how we need to communicate if it is falling off. How do we make sure the other care unit knows, hey, we didn't do the 4-hour because they were admitted at 3 hours. It's got to be done.
So this is Gunderson. This is Jennifer from Gunderson, and we actually just worked on our order sets, and we think we figured out how to do that. So we can certainly share that with you. We'll have to talk to our IS person because we're quality people, so we don't know how to do that. But we have it built into our order sets so that it will not fall off when the patient transfers to the floor. So we can help you with that if you want us to.
That's awesome. Thank you.
Yeah, will you just make sure Jamie gets your information and then I can email you?
Sure, we'll do.
Thank you.
Yeah, we'll put you guys in touch and end that conversation. If it's available to share with a broader group, let us know as well, and we can we're actually putting together sort of a frequently asked questions on sepsis resource, so we'll be able to include that.
Okay, will do.
And again, I love the collaboration, and the other thing you could think about is redundancy, right? So a lot of, I should say a best practice that we've also identified is a handoff tool. So some sort of SBAR report specifically for sepsis when handing off septic patients. And on that checklist, when you're having that nurse-to-nurse, the question is, do you have an order in your EHR for the repeat lactate? And then if they say, no, we don't have that order yet, but, it's make sure the physician knows that order, when was the initial lactate drawn, what was the number, and can you please prompt the physician to put in that repeat lactate order, or hopefully your floor nurse is even empowered to put in that order. So that's just another layer of redundancy you can add to make sure that that ball doesn't get dropped. You are not alone. Here are some of the comments. I've actually put together quite a few comments on lactate just because from the physician standpoint, I get a lot of comments on it. So a few things I've been asked is, what are the units? They should be millimoles per liter. And so there are some that are still doing the milligrams per deciliter. And if you had that, you would divide by a factor of 9. So that's kind of a nuanced lab thing. But if your lab for some reason is reporting not in millimoles per liter, it's probably milligrams per deciliter you divide by 9. Nuanced question there. Which lactate are we talking about? So if in some EHRs, you put in lactate and you'll get an L lactate and a D lactate. We are always talking about L lactate The D-lactate is this weird niche lab that is only used for like short gut syndrome and GI issues. And so if you have one of those lab profiles that just gives you every lactate under the sun, just make sure that we're talking about L-lactate. Probably the most common question is whether peripheral lactates correlate to arterial lactates, and they correlate very well. So that literature has been signed, sealed, delivered. The myth has been busted. Venous lactate is perfectly acceptable. You can have the tourniquet up for 20 minutes, and it's still perfectly acceptable. So obviously, if a blood draw is taken 30 minutes, and you've had the tourniquet up that long, you probably want to just take it down again and give that patient a little rest and then restart. But up to 20 minutes of venous lactate should still be accurate, and it does not need to be on ice for the first 15 minutes. That's another common question is, well, should these all be being on ice, and are we getting accurate samples? And if you ever do doubt your sample, if you get a lactate of 20 and the patient doesn't look that sick, the correct answer, I would say, is resend 2 lactates, an arterial and a repeat venous, and just make sure everything is correlating correctly. And then turnaround time, if you're a director, an ED director or an ICU director, turnaround time for lactates, the national standard is less than 30 minutes, ideally less than 15 minutes. That lab only takes 1 minute to run on the machine. So the extra 29 minutes there are delays in getting it to lab and putting it on the machine and reporting it and putting it in the system. And so if your lab is taking more than half an hour, that is well above the national standard, and you should probably look into ways to expedite that lactate, because that's a key lab that clinicians need to make their decision. And if you do want to think about an iStat in the ED, that machine costs $11,000, which as a capital expense is pretty affordable, and it also provides point-of-care troponin and point-of-care venous lactate, which are useful for emergency physicians. That was a lot of info all at once, I know. All right, maybe some more controversial topics, or hopefully not controversial. What is going on with the 30 cc per kilogram bolus? We know that across the state, physicians had a lot of initial resistance in CHF patients, end-stage renal disease patients, or morbidly obese patients. We've done a lot of work to educate about the importance of making sure a patient is really septic, and then if they are giving the 30 cc per kilogram bolus, even in cases of CHF. We've emphasized that in cases of end-stage renal disease, that physiology doesn't actually make a lot of sense. Those patients don't third space only into their lungs. They third space everywhere, and they can absolutely handle a 30 cc per kilogram bolus fluid challenge. And then we've emphasized that morbidly obese patients can still get the 30 cc per kilogram bolus. You are not going to flood these patients. However, the metric does give us an out. If you want to use ideal body weight, you can, and we're recommending using ideal body weight only in patients who are over 200 kilograms, which is very, very few patients really. So most patients are still getting 30 cc's per kilogram bolus, regardless of weight. What's happening at your hospital? Is this where you're failing your Sepsis-1 metric? I think a lot of us are. And if so, what's the state of affairs? Yeah, please.
How about the patients who go into pulmonary edema? I mean, that seems to be a big deal here, too, at Aurora Bay Care in Green Bay.
Yeah.
Where they're stopping the fluids because the patient's going into pulmonary edema, but there's no way to really indicate that. Yeah.
So what I would say is, so great question is, the patient harm, right? We don't want to be doing cookbook medicine and blanket, flooding people with fluid and harming them. The CHF patient who's going into pulmonary edema is a specter. It is not a reality in my experience and in the literature's experience. And I'm happy to, talk about this with any and all clinicians. What I would say is this, first of all, we as physicians, we talk a lot about CHF as though all CHF is, created equal. There's a lot of people with CHF on their chart who have a preserved ejection fraction. So their last echo, their ejection fraction was 65 or 55 or 45. They can absolutely handle a fluid challenge. Now, for your CHFers who truly have, New York stage heart failure, decompensated CHF, 10% ejection fraction, not preserved, failing their medications, if they're truly septic, they still need the 30 cc per kilogram fluid bolus, and there is a small but real chance that they could be fluid overloaded. And the metric actually gives you an out on this. So if the physician documents fluid overload in that patient, and that should be documented by listening to the breath sounds, the patient becomes hypoxic, or a chest x-ray finding, then you should not continue to resuscitate that patient with IV fluids. You've kind of overdone it, and that's an okay out. You're out of the metric. You won't fail the metric. When you said your question, though, it kind of sounded like physicians were saying it without providing clinical evidence. Is that what I was hearing? That you're just getting a lot of those charts where they say the patient was fluid overloaded?
No, but where is it that you can document that on the metrics so that you don't fail it?
Oh, there. We'll get back to you on that specific point. I don't know if I have the data abstraction level of expertise, but you are allowed an out. If you are creating patient harm by administering fluids and that's documented, you should not continue administering fluids. And so, but the nuance or the rub is you actually have to give it a college try first. So when you have your CHF patient and you think they're septic, you should be administering 30 cc's per kilogram normal saline. And then the thing I always tell clinicians is that when you see CHF on the chart, that doesn't mean don't resuscitate this patient. You know, we have to prioritize cardiovascular system over pulmonary system in sepsis. That is the name of the game. We do harm in medicine all the time. We give patients chemotherapy. You know, we submit elderly patients to surgeries and anesthesia that are potentially life-threatening. We do risk versus benefit all the time. In sepsis, you have to support the cardiovascular system if you want that patient to survive, and that means giving 30 cc's per kilogram normal saline. The nuance in CHF is that patient needs to be reassessed more frequently. So when I see CHF on the chart, I don't think, oh, I'm not going to give this patient fluids, I could fluid overload him. I think this patient is slightly at risk of fluid overload. I need to have a communication with my nurses to reassess every 30 minutes, you know, reassess every 500 cc's, really make sure that we're listening to their lungs, that the O2 stat in the chart is up to date, that we're talking with the patient and saying, how is your breathing doing? Look at their respiratory rate, and making sure that we're not fluid overloading them. So in my mind, this is more a reminder that we should be assessing that patient more frequently and really keeping tabs on their resuscitation in a more nuanced way than your healthy 30-year-old who's septic. And we'll get back to you on the where you actually abstract or like put in that exclusion. We have that information. I just don't know it off the top of my head.
That would be great.
Of course.
So this is Kathy. Is there I don't even know how to word this. If we use ideal body weight and it's below the recommended weight, Dr. So-and-so is just, oh my gosh, I think they're in fluid overload, I think they have CHF, whatever the reason is, and I just am not comfortable with 30 mils per kilogram. I guess how detrimental or how can we re-educate if that's necessary about giving them the real fluid or really looking at what determines that using ideal body weight?
You know, I think that would be, if you've got someone who is giving the 30 cc's per kilo but always using ideal body weight, I would just let them roll. You know, that is chasing a windmill at that point. You've kind of gotten them 9/10 of the way, and do you want to spend your resources nudging them that extra 10th of the way? The answer is the literature is nuanced. I would say it skews heavily towards the use of 30 cc's per kilogram all the way up to 200 kilos. That being said, if the metric now allows us to use ideal body weight, it's a reasonable argument. It's not totally unreasonable to say I'm going to use ideal body weight. And so I think it's probably not worth your time, to be honest with you. You're not going to fail the metric. The patient's getting plenty of fluids. You know, if they're 150 kilos, well then, you know, sure, maybe that's 1.5 liters of fluid they didn't get that they would have gotten using actual body weight, but I don't know, where do you want to spend your time kind of thing? Sounds like that doc is actually already on board with most of the metric, and I wouldn't really pick that fight necessarily. If you want to have the physicians have a journal club about ideal body weight, in fact, if you jot that down, Annie, I'll provide you resources in terms of journal articles with the literature basis for only using ideal body weight in extreme obesity. That'd be a great journal club to have your doc sit down and say, hey, what do we as a group want to do? But coming from quality, I think it would just sound like you were being nitpicky. You know, if the docs want to have an internal discussion about their practice and talk about the latest evidence, I think that'd be a really cool discussion for them to have, and maybe they could come around organically if you just present them with the evidence.
Yeah, I think the articles would be great. And part of the problem is getting them to document that they're using ideal body weight. And that's an IT thing. Maybe on the back end, Epic can say, you know, hey, are you using ideal body weight? And at least it would trigger them to, oh, yeah, I got to document that.
Kathy, we have that on our order set, it's a box that they check. I know we're on Meditech, but they check that box that says ideal body weight, and it does the calculation with the ideal body weight. I don't know if Epic can do the same thing.
I'm certain it can. Do we? I'm sorry, who was that? We do?
Yeah, this is Nikki from Medford. We do have that in Epic. I can send you that information.
That'd be awesome.
The reason I like that CMS gave us that out with body weight is if you do have physicians who are still reticent about that much fluid, and they've heard all the arguments, and they really dug their heels into the sand and they're not budging, that's sort of a consolation prize. We can say, well, could you at least meet me here? Could we do ideal body weight, and maybe try to influence them in that way? But I actually think the word is getting out pretty well. We are not fluid overloading patients at the rates that people were initially concerned about when this first came out. And really the key is choosing patients who are actually septic. If we just took a bunch of CHFers and gave them 30 cc's per kilogram, we probably would fluid overload them. But we're selecting our patients who have bacterial infection, who have vasodilation, whose IVC is dry, and we're fluid resuscitating them so they can actually get the antibiotics to their organs. And it's been working well in Wisconsin. You can always keep that metric too. You could say number of CHF patients fluid overloaded and show that to your physicians. I suspect your number will be in the 0 to 1 range.
Dr. Redwood, I have a question.
Yeah, please.
So I see more of our ED providers ordering 1 bag of saline versus the 30 cc's per kilo bolus. Is it best practice to order the bolus?
Absolutely. Order the bolus.
How can I prove that?
You can cite me if you want. What we do, it's. I wouldn't say there's established literature on how to do this metric right. It's really based on your hospital culture and what's going on. But what we do have is we have this network of Wisconsin hospitals, and we all get together and we say, what are you doing? How are you doing it? And we've recognized firmly that when a single bolus is ordered, the ball gets dropped. You're doing something else, you get caught up with another patient, and it's really about ordering 30 cc's per kilogram from the get-go. So if your physician is worried about fluid overload and they want to have a conversation about it with their nurse, a better way to do it would say, I've ordered the 30 cc's per kilogram bolus. Can you get back to me after the first liter and tell me what the repeat lung exam is? So if you want to put that in your order set, that would be a great order set to have. 30 cc's per kilogram fluid bolus, nurse to re-examine lungs after first liter and report to physician back, or something like that. That might be a way to sort of navigate those waters in a artful fashion. But yeah, if you have to go back on as an emergency physician, so I practice full time, I am trying on most patients to just order things once. The patient comes in and I want to open their chart one time, put in all my orders, put in all my meds, and then, only do touchdowns if they're failing therapy or something new comes up. So this idea that we're going to go back and order repeat fluids on septic patients is pretty unrealistic from a workflow standpoint.
And then if it's like, we're missing the total volume that is required because they're not calculating out the remainder. So that's where we're falling out.
Yeah, exactly. I would strongly advocate for the order set to have the 30 cc's per kilogram normal saline. And do you have in your hospital? Do you have a ED physician champion for sepsis, or not so much?
Yeah, we do.
Okay. And is that person? Do they seem to be on board with a 30 cc per kilogram fluid bolus?
Yes, but he'll occasionally order the saline, but then he'll do the calculation to meet the 30 mils per kg. So he's like a super champion. So does your order set currently say 1 liter, or does it say 30 cc's per kilogram? It has the 30 cc's, but it's not often used.
So the physicians are not using the order set. That's what I'm hearing.
Consistently, about 50%.
Yeah. I think that's an appropriate time for quality to touch base with your physician champion and say, how can you nudge your docs? Like you're on board, I'm on board. We're clearly missing the metric because of fluid resuscitation. This is clearly the cause of it. what can we do to influence physicians to use that order set more? And as an ED director or just a peer, they're going to have a better idea of how to influence their peers probably than you have, and hopefully can have that hard conversation. I'm happy to chime in. I usually chime in when your physician champion isn't on board, but if you have a physician champion who's on board, they're the ones who know their docs and know their habits and know how, the clunky parts of your EHR, and they'll be able to hopefully influence their peers if they're motivated.
Yeah, thank you so much.
One of the things that we found the most with that is that our providers weren't educated on what benefit the sepsis order sets had to them. That the repeat lactate was on there, that to automatically trigger the fluid bolus calculations. So what we did in our organization is we actually created education around what is the benefit to meeting these metrics through using the order set. And that was helpful, and we are getting better engagement. And some of the providers didn't even know these existed, that the sepsis order sets existed and what was in them. So.
Yeah, absolutely. And if you ever, as physicians, something that really speaks to me is mortality, sepsis mortality, and then level of care upgrades. So if you want to run your internal numbers on sepsis mortality and level of care upgrades, most facilities find that as your compliance with SEP-1 goes up, your mortality goes down and your level of care upgrades go down as well. And that's pretty compelling evidence for physicians. It's kind of an extra number to run, but if you've got kind of people who don't believe in it yet or can't see the value in your own hospital, you can say, look, we're really saving lives here, at a hospital A, B, or C.
Yeah, agreed. And we see a lot more severe sepsis than shock, and our mortality has always been low, so it's kind of a hard sell that way too, because we're already doing well.
Well, that's good that you're doing well.
Yeah.
Yeah. I hear you. I wonder. Well, if all else fails, please put me in touch with your physician champion. I'm bobby.redwood@gmail.com, and we can always have a kind of heart-to-heart and talk about where to go next. Very happy to do that.
Thank you so much.
Let's talk antibiotics. Monotherapy, combination therapy. Do you need Vanco or not? Are people finding that antibiotics are the sticky wicket at your hospital?
No.
No, we jumped over that bridge.
Good. It's nice. Some of the broad spectrum, the monotherapy options are actually pretty reasonable. So they've got cefepime on there, they've got ceftriaxone on there, they've got Zosyn on there, and those are sort of tried and true emergency medicine favorites. I find the most common issue is that when the patient has a cephalosporin allergy, there's not a lot of non-cephalosporin options on there, and so that's sometimes when are we really thinking about gentamicin and clindamycin or something like that. And so that's the one innovation I've sometimes seen is if you do have if the patient has a cephalosporin allergy, have a specific recommendation for that. The other thing is, a lot of questions of we're in the age of antimicrobial stewardship and antibiotic stewardship. Questions sometimes pop up about antibiotic stewardship in sepsis. And my general advice is that when a patient is truly septic, when they're in the emergency setting and they're septic, that is not the time for antimicrobial stewardship. That is the time to throw the book at them. So you're not going to save a resistant organism by holding back on antibiotics for that patient in the ED at that time. You'll save your resistant organisms by not treating viruses in the clinic, by following your biogram in general and choosing, treating UTIs and basic cellulitis with more narrow spectrum agents. But once the patient's septic, the cat's kind of already out of the bag and it's time to throw the book at them. And so the general advice is early recognition of septic shock and early administration of antibiotics. For every hour in those first 3 hours that you administer the antibiotic earlier, the mortality goes down by 10% based on the literature. And then empiric therapy or combination therapy should be de-escalated as soon as you know what you're treating. So when blood cultures come back, you want to narrow as quickly as possible, ideally within 3 days. So you might start someone on vancomycin, but once you realize that it's a strep cellulitis, you can narrow that down to something like Keflex or ceftriaxone. And then duration of therapy for sepsis is ideally 7 to 10 days. So there was this era where septic patients were getting 21, 30 days of antibiotics, basically being on antibiotics throughout their entire hospital stay. And in the ICU setting, we're dialing those antibiotics down sooner than we have in years past. And then people often forget about antiviral therapy. So if you do suspect viral sepsis, which can, flu season, we lose people to flu every year, you absolutely want to start antivirals much in the same way you would an antibiotic. So if you think it's viral sepsis, you start antiviral therapy exactly like you would antimicrobial therapy. And don't feel bad about stacking those two either. If it's a flu patient with an infiltrate and you're not sure if it's bacterial or viral, you treat them with both antivirals and antibiotics, and then de-escalate cares once you get cultures back. Vasopressors. Oh, yeah, please.
Yeah, question. Mm-hmm. We have a PI project going at our hospital trying to get antibiotic in 120 minutes from door to antibiotic in the ED. Do you think that's a reasonable goal?
Yeah. Some of you may be aware the Surviving Sepsis campaign, which is not CMS, this is not associated with the metric, they are advocating for antibiotics within 1 hour of presentation, which is a pretty tall ask, actually. You've got to diagnose sepsis and sometimes organ failure within an hour. Are we really getting our labs even back within that time frame? But 120 minutes, I think, is very reasonable. I think the 3 hours, now that we have, at my hospital, we have sepsis up and running, is actually pretty generous. I would say we routinely get our antibiotics in before 2 hours, sometimes before 1 hour if it's an obvious presentation. The tough ones are occult sepsis. So the tough one's the little old lady who's just acting a little bit funny, and then you get the lactate back and it's 6. And they weren't tachycardic, they weren't febrile, they weren't tachypnic. You get your urinalysis, a couple hours later, and you realize that patient actually has a pretty severe case of urosepsis going on, but their immune system isn't robust enough to mount that immune response and show us that they're septic. Those are the challenging patients who I think antibiotics are sometimes delayed in, and that's where the repeat lactate or the initial lactate really kind of saves our butt as clinicians. But 2 hours is a very reasonable goal. I think you can get there. And if you're consistently getting under 2 hours, that's very good sepsis care. And CMS may be asking us to do 1 hour. We'll see. Who knows what the future holds? That would be pretty stressful.
I suspect they may change time 0 to triage time.
Yeah. Yeah, it's hard to guess what's down the pike, but the core measure has been the Surviving Sepsis campaign has sort of been leading the core measure, and they are going in that 1 hour direction. So we'll see what 2020 holds in store. All right, we're actually doing pretty good on time. We're sort of at the end of our topics, and we've had some great contributions. Any questions on vasopressors in our last couple of minutes?
This is Debbie from St. Vincent's. Where we're struggling is getting the blood pressures after the boluses, to trigger the provider to get the vasopressor type of thing. So
you're having the patient's been fluid resuscitated, they're still hypotensive, and nobody's dropping the central line and starting vasopressors. Is that what I'm hearing?
We do have follows.
And I sort of speak off the cuff. There's no judgment here. Like this, honestly, all hospitals across the state, we're all having the same issue, so we're all in this together. I totally understand. The things I would say are, first, empower your nurses. The question is, or the wrong way to get vasopressors started is to say, hey, are you aware that the patient's blood pressure is now 60s over 30s? The question is, the patient's blood pressure is 60s over 30s. What's our plan to start vasopressors? And you can get them started in multiple ways. You can start with a peripheral line. So norepinephrine is okay in a large bore IV for up to 24 hours. And so if you know you're going to be transferring the patient, for example, and your physician cannot place a central line or doesn't have time to place a central line, peripheral vasopressors are absolutely an option. And then if you do need a central line, interosseous line is a fine option. So you can go to the tibia, put in an interosseous line, and that's a central line where you can apply vasopressors. As an emergency physician, I do find that I'm trying to run the room, and sometimes the pressure conversation, I'm weighing my options in terms of, do I have time to place a central line right now? So giving your clinician those outs can be a meaningful way to do that. And that might involve educating your nursing staff and saying, hey, did you know peripheral pressors are okay? Did you know interosseous lines are okay? And offering clinicians those as an alternative. But this is a time when our nurses can nudge our docs for sure. We as clinicians want to think the patient's going to get better, as docs, and we want to sit there and watch and wait. And the spirit of the metric is the exact opposite of that. We're trying to snap into critical care mode and intervene early and really get those pressors started. The other thing I sometimes struggle with as a doc is we have a lot of patients on blood thinners. So, you're on warfarin or you're on Eliquis, and that becomes a dangerous line, a dangerous central line. And I'm not really convinced that they haven't turned the corner yet, or they're not going to turn the corner. And so that ask of me to put in a central line is kind of a big procedural ask. And again, in those patients, I will opt for peripheral pressors or use a intraosseous line to decrease bleeding risk. Anecdotally, with this metric, I'm seeing patients turn the corner a lot quicker. So I'll see that I'll have pressors on for a few hours, and sometimes I'm already de-escalating those pressors before I admit them to the ICU. So I'll have these kind of quick turnarounds where I do my 0.5 norepinephrine, 0.5 micrograms per minute. I run it for a couple of hours. The fluids kick in, the antibiotics. Like when you give patients antibiotics, they lyse all their cells, all the bacterial cells die, they spill out their endotoxins, and your patients will sometimes have this vigorous vasodilation response where you see their pressors drop really precipitously, and then they sort of clear out those toxins. Their kidneys break them down, they pee them out, and you'll see that they actually get their blood pressures back up organically, and you only need pressor support for a few hours. That's especially true with gram-negative rods. And so I'll see in the ED sometimes I'm sort of nurturing my patient through that after-drop phenomenon after the antibiotics, and then they're basically on their own without pressors again. So if the patient's in the ED 6 hours, I might have them on pressors for a couple hours and actually be able to de-escalate those while they're still in the ED, and I never place the central line. That's probably a little more nuance there. I know we want to respect everyone's time. We're at 1 hour right now, and so if you have any follow-up questions and you want to email questions to us, we're going to be putting together a best practice resource with frequently asked questions, and we can absolutely answer those questions at a later time. But I thank everyone who chimed in. I thank you for your attention, and good luck treating sepsis at your hospital.
Thank you all for joining the Sepsis Town Hall. If you have additional questions, as Dr. Redwood just said, or need assistance with your sepsis quality improvement efforts, please reach out to either Dr. Redwood or myself. We are happy to assist. If you have a need for any of the other HIN topics, please let us know, and we'd be happy to put together education on those also. Thank you, and have a great rest of your week.